You note that you hit a guitar string or piano key softly, you hear one tone. You hit it hard, and you hear multiple tones. These are called overtones or harmonics. And this is exactly what we do with our microbubbles when we're doing contrast ultrasound imaging. And the reason why we do this is we can use some of these overtones to separate out bubble signal from tissue. Because when we're doing contrast ultrasound imaging, we're not so interested in the tissue signal, we're interested in the bubble signal. And the tissue doesn't do this like bubbles do, okay? Now, just about every ultrasound system that's out there has contrast-specific technology to specifically detect the microbubbles. And we won't go into all of those, but we'll show you in the live demonstration how you would, the general principles behind ringing a bubble. So first, let's talk about the bubbles that we have available to us. This is a partial list of the bubbles that have been made for commercial use, okay? This is about, this list I just cut off. It's about 3 times as long if you look at all the bubbles that have been developed. But the principles are the same, which is if you're going to inject a contrast agent into a patient via vein and expect it to stay stable through the microcirculation and through IV injection, through the pulmonary circulation to the LV, you need it to last. It can't deflate. And so there's 2 things that have been done to make microbubbles stable so that they don't deflate and lose their gas. The first thing that's been done is to put a shell around it. And there's lots of different shells that have been used: lipid shells, albumin shells, polymer shells. But the other thing that you can do is you can put these gases inside of them that don't diffuse out very readily. These are very safe, inert gases, and they're big. They're large molecular weight gases, low diffusivity. And so what happens is if you make a bubble that has a shell and is high molecular weight, it stays as a nice big plump bubble that can ring in the ultrasound field. And so in the US, we really have 2 agents to choose from, which are Optison and Definity. Here you guys have Sonaview, which is also in Europe, and Definity. And so all of these bubbles have shells and gases, but one of the key things to remember is the size. These bubbles are generally about 1/3 the diameter of a red blood cell. Because they're smaller than the size of red cells, they don't get stuck. Okay? They pass through the microcirculation without lodging. Okay? So those are the 3 principles, which is you have to have a shell, a special gas to keep the bubbles plump, and the bubbles have to be small enough that they can pass and be safe and move through the capillaries. So these microbubbles as contrast agents are used primarily in cardiology for left ventricular opacification. We'll talk a little bit about perfusion at the end here. But if we go back and take a look at where this helps, a lot of the early studies looking at contrast ultrasound and contrast echocardiography specifically look at what situations bubbles really help you. And a lot of the studies, and there are many studies, I just put some of them down here at the bottom, unequivocally showed that using contrast will increase the number of interpretable segments that you can see. It will increase the likelihood that you're going to have an interpretable study. It decreases inter-observer variability. Importantly, it increases interpreter confidence. You guys know that echo is used as a point-of-care technology. You not only have to be able to make a diagnosis, but you have to be confident about it. If you're going to make a critical decision on a critically ill patient, you need to have confidence, and contrast will give you this. It improves accuracy of EF and volumes, which is very important in the world of ICD, CRT, and all of these things. It can salvage post-exercise studies, and it is cost-effective in select settings. So what are we talking about? Here is the, it's kind of bright, but here's the average obese American patient. Let me count for you. 1, 2, 3, 4, 5, 6, 7 centimeters between the probe and the apex of the heart. This is a large individual. This is why we see nothing in terms of the endocardium here. With the administration of contrast, you can pretty much, with confidence, say that I can see every single segment now on this apical 4-chamber view, and I can quantify this. So this is low normal to very mildly reduced global LV systolic function. We had no idea what was going on in this patient without the addition of contrast. The application of contrast in specific situations has been shown to really improve patient care and decrease cost. This is I think one of the best studies that has been done to show this. This is from Bill Zogby's laboratory in Houston. And what they did was they just recruited patients. They didn't recruit all patients because that's unreasonable. We're not advocating using contrast in everybody. But what he did was he took patients who had technically difficult studies, either inpatients and outpatients. And here you can see that the vast majority of patients actually were inpatients, either in the wards or in the intensive care unit. And so they just selected patient studies that were technically difficult. Okay? So here you can see in red is technically difficult, yellow is uninterpretable. Okay? After recruiting these patients and trying to figure out what was going on with these folks, they administered contrast afterwards. And with blinded reads, you can see that the interpreters of these studies thought that just about every single study went from technically difficult or uninterpretable to something that was adequate for interpretation in terms of LV systolic function. So this was a really good study that actually showed that there was a great impact of using contrast in patients whose windows were not just horrible, but were very borderline. And what they showed in this study is actually the use of contrast was cost effective. On a per patient basis, it actually saved about $150 per patient because they didn't need to go on to other testing. So this is showing you in either blue or yellow those patients in whom another test was avoided. Now what's amazing in this study was this was just resting echo patients with technically difficult studies. If you look at contrast echo for stress echo, the cost savings is even greater because if you send somebody for a stress echo and you can't really tell what's going on, almost all of those patients are referred for a different type of technology, usually nuclear scan. Okay? And so this showed you even with just mostly inpatients that the use of contrast could actually be cost efficient. Now, the American Society of Echo has guidelines that tell you when to use contrast. There's a document out there. It's the first author is Sharon Mulday. Now, I do a lot of leadership work for the American Society of Echo, but this is not the best document in the world. I disagree with the way that they have advocated using contrast. Essentially, they say you should use contrast in anybody who you cannot see two adjacent segments very well. I don't think that's the way that you should be thinking about when to use contrast for left ventricular opacification. This shows you how I think about who to give contrast to. There's two questions to take into consideration. The first question is, what is the quality of the images before contrast? Are they poor, fair, or good? And then you have to say, what is the indication for the study? Why is the patient being sent for echo? So for example, down here at the bottom, if a patient is being sent for pericardial disease, question constriction or restriction or tamponade, contrast is unlikely to add all that much. And so the low percentage of patients really should be receiving contrast. Okay, even if the study is kind of technically or it's not going to add that much. But then if you look at certain things such as echo being done in patients who are actively having chest pain and you want to know, is this angina? Or looking for LV thrombus, stress echo, change in EF in patients undergoing chemotherapy, quantification of EF or volumes for ICD or IV. In these situations, you not only need to be able to see every segment, but you need to see every segment very well. Okay? And in those kind of situations, even if the study is fair, the contrast will still help. And in certain situations, even if it's good, contrast will help. Let me show you a case as an example. This is a 66-year-old male with an ischemic heart failure, which has been known, status post CABG, admitted with a stroke. Echo was requested by the neuro team for evaluation of LV function and to rule out thrombus. So here's the study. So here's the non-contrast intensive, and I would call this a fair study. It's not poor, it's not good. You can kind of tell that LV systolic function is globally reduced severely. If you take a look here, TAPSE is way down. Mitral angular excursion from the base to the apex is way down. There's early closure of the mitral valve, which means LV-EDP is high. So there's no mystery that this person's LV systolic function is down. Are you happy with this? I wasn't happy with this. Why? What was the indication for the echo? A stroke. Exactly right. You had contrast in this patient, and two things happened. So number one, you can tell, number one, exactly what the LV systolic function is, which is severely reduced, but you can also tell that it's in a segmental pattern. The basal septum here is working better than the distal septum, which is akinetic, apex is akinetic, distal lateral wall. Here's the two-chamber view, which also shows a segmental pattern with the apex working worse than the basal segments. But the other thing that you see here is a gelatinous thrombus. You had no idea that was there on the non-contrast enhanced study. So remember what the indication was. So it was, I would put this, if we think about that earlier slide, I would put this as a fair study. But the indication for this is for ruling out LV thrombus in this patient, which we've been able to do only with the addition of contrast. Here's another case that shows you that point-of-care contrast echo can really help you make decisions, very important decisions, very rapidly by increasing your confidence and your knowledge of what's going on. So this is a 68-year-old male who has escalating chest pain with moderate exertion. Was referred for supine bicycle stress echo, had baseline left bundle branch block, as you can see here, and very poor echoes at windows at the baseline. So here is the baseline echo, and that is not very good. We didn't want to send him for a stress nuclear, mostly, the left bundle branch block gives us an artifact on nuclear, which is a little bit difficult. You can do vasodilator stress echo with nuclear pretty reasonably. This person was actually sent for a stress echo. Does anybody want to do stress echo when the baseline images look like that? I don't. I just send them off for nuclear immediately. But we didn't have to. We didn't have to. We actually were able to use contrast. And with contrast, we were able to get a diagnostic study. So here, for example, in this patient, this is the parasternal long axis view. It's kind of a low, so close to an apical three-chamber view. It's a low apical window. But here you can see the anterior septum, inferior lateral wall at baseline, low dose exercise, high dose exercise, and then recovery. So this is a supine bicycle stress echo. And here you can see that at baseline, you see the dysynchrony of the septum with the left bundle branch block indicating it's normal. Here you can see that even at low dose, and especially high dose exercise, high level exercise, the anterior septum becomes completely akinetic. Here's the apical four-chamber view. Once again, septum looks okay, lateral wall. Low level exercise, you have this severe wall motion abnormality involving the apex and septum, but also the lateral wall, distal lateral wall. And here you can tell pretty well. You can tell that the septum actually stays stunned after exercise. And here's the apical three-chamber view. And what we didn't see before was really in the apical three-chamber view, there was actually hypokinesis even here at baseline. And then we had a little bit of a pickup of the wall motion. And so when you look at this, we went from not being able to see anything at rest to having a diagnostic study. So the results of the stress echo, what are they consistent with? Yeah, this is multivessel disease. So we were able to take a completely worthless study to something where we were able to detect a multivessel disease in this patient by administering contrast. And for anybody who's interested in this person's angios, here they are, which shows a severe three-vessel disease, bad disease in the circumflex, tight disease in the LED, and occlusion of the RCA with right collaterals. Besides the standard applications, I need to see wall motion better. I need to see LV volumes and LVEF better. There are also niche applications for left ventricular opacification. These are situations where using contrast really helps in certain disease states. Some of these I've got listed here, and this is a partial list. One, we use this a lot in stress cardiomyopathy for confirming that the pattern of dysfunction is atypical for coronary artery disease, whether it's a classic apical ballooning syndrome, Takasubos, or whether it's an atypical pattern such as mid-segments or basal segments associated with intracerebral hemorrhage. It's very good for apical hypertrophic cardiomyopathy, non-compaction, as I'll show you. Whenever you're trying to look at an LV mass, pseudoaneurysm, and doing something called vortex analysis. I'm not going to talk about all of these things. I'll show you a couple of examples. Some of these things that I'm not showing you today, I'll show tomorrow at our contrast. So I'm going to show, for example, tomorrow things such as perfusion imaging and looking at ventricular masses and pseudoaneurysms. But here's an example of a ventricular non-compaction. So here's a patient referred for heart failure symptoms. Here is the parasternal short axis apical four-chamber view. And here you can see that the LV systolic function is not completely normal. You get the hint that something is going on here, that there may be hypertrabeculation here of the apical lateral wall. I can see better on my computer than you can probably hear. It's kind of bright here. But the administration of contrast, especially with the room being so bright, the administration of contrast really brings out what this is, okay? You give contrast to this patient, and here you can see this massive amount of inferior lateral, even up the septum, of hypertrabeculation. This is non-compaction. The non-compacted ventricular myocardium here is about 3 times as thick as the compacted myocardium. And here you can see the contrast going out into the recesses of this non-compaction. So in situations where it's not quite clear whether this increased stuff here is from a hypertrophic process or from non-compaction, contrast to see the blood flow into these recesses can be very, very helpful. So that's left ventricular opacification. We're going to actually do a live case. Kim and I are going to do a live case in a little bit to kind of show you how to set things up for this. But I want to also share with you some of the things that you can do with perfusion imaging. So this is off-label use of contrast echo, but this is something that we do daily in our echo lab. And the reason is it really, really helps make point-of-care decisions in the emergency department, in the ICU, and even in outpatients in the echo lab. So perfusion imaging with contrast ultrasound is based on the principle that our microbubbles behave just like red cells in the microcirculation. This is the microcirculation of a muscle bed, and what I've done here is these are some bubbles that I've made in my laboratory, and I made them fluorescent. And so here you can see that the bubbles, this is a small arterial, capillary bed over here, and a collecting venule. And you can see that these bubbles behave just like red cells in the circulation. They don't lodge. Shown in the graph down here, the velocity of bubbles going through the capillaries is the same as red cells going through the capillaries. And when we look at the myocardium, so if we give contrast, we see the contrast in, this is a short axis view, we see contrast in the cavity, LV cavity. But we can also see the contrast as it's moving through the microcirculation of the muscle. And when you actually look at the muscle, the heart muscle, even though I'm showing you arterioles and venules here, the vast majority of all the bubbles that are moving through the mass of the heart is capillaries. Within the muscle of the heart itself, about 80% of the blood volume in the muscle is in the capillary compartment. Most of our bigger vessels are on the surface, okay? So most of the blood is in the capillaries. And so when we look at the signal coming from bubbles as they're moving through the microcirculation of the heart, we're pretty much looking at what's going on in capillaries. And that allows us a very unique look at perfusion. Now, the way that we actually measure and quantify perfusion is not just by looking how bright it is, but what we do is we infuse microbubbles in so that there's a constant concentration of bubbles, and then what we do is we destroy them. Okay? So here are bubbles, and what I'm doing here, if you have a microscope and an ultrasound machine, you can have a lot of fun. And this is essentially showing you bubbles, and I've just turned on a single frame of ultrasound with high power, and I destroy all these bubbles. What that allows us to do is the following, which is, here is a heart, apical 4-chamber view of a patient, and what you're going to see here is a bright flash right there. That's our destructive flow. What we've done is we've destroyed all the bubbles within the volume of the ultrasound beam. Remember, ultrasound is not an ultra-thin slice, it's a slab. Our ultrasound beam has a thickness called the elevational plane. And so when I'm imaging all of this bright yellow stuff in the myocardium, that's bubbles within a volume of tissue. And then what you see here is this bright flash, bam, and the heart becomes black. And then you see the bubbles coming back in. You see that a little bit better here in this picture. This is a brain. So here's a brain. You're going to see the flash, and then everything gets dark, and then the bubbles come back in. Okay? And so what this is the destruction of bubbles in this tissue, and then watching how fast they come back in. And that's essentially how we do perfusion imaging. And it doesn't just have to be in solid organs like that. This is looking at vasa vasorum in a vessel. So here is a femoral artery with a very robust atherosclerotic vasa vasorum proliferation. And here you can see when we hit it with ultrasound, everything disappears, and then we're able to even measure vasa vasorum in the blood vessel. And so the way that we measure perfusion with contrast ultrasound is we do a destruction right through here, and we measure how fast the signal comes back in. So do you guys see in the lower left here, this is a short axis view of the myocardium. The blood pool is much brighter than the myocardium because it's 100% blood. Myocardium is only about 5 to 10% of it is blood. Okay? A lot of it is myocytes, muscle, some of it is blood. And we destroy bubbles and watch how fast and to what extent they come back in. And so what we do is we see how fast it comes back in and then how bright it eventually gets. And that gives us everything that we need to measure perfusion, blood flow. What is blood flow? Blood flow is just a volume of blood moving at a certain rate through tissue, right? So the volume of blood is measured by this plateau. We destroy and replenish. How bright it is just reflects how much blood there is in the myocardium, blood volume. And we fit this to an exponential function to get the rate, okay, the refill rate, which is the rate of transit of that blood through the myocardium. So the product of the blood flow and the rate that it's moving through the myocardium gives us blood flow. And we can quantify that in mLs per minute per gram of tissue. And what that does is it allows us to look quantitatively at blood flow and also spatially. So this is an example of a critical stenosis. And if we do a destruction replenishment sequence, here in the completely normal area, we see that right after destroying, the signal comes back very quick and it becomes very bright. If we look at the edges of this ischemic zone, you can see an intermediate curve. And as we move further and further towards the center of this risk area, it takes longer and longer and longer for that area to build. So this is the first frame, 1 second. This is 10 seconds after the destruction. And here you can see that it takes a long time in the presence of this LAD stenosis for this to build. So it's viable. There's some intact microcirculation here, but it's very slow to build, so that it's steep. And so this gives us a very powerful tool to be able to quantify blood flow spatially in the heart.
That can be used in many different circumstances. One of those circumstances is for evaluation of chest pain in patients with acute MI. These are the determinants of infarct size in a patient who's having an MI. As most of you guys know, if you have a coronary occlusion, the pink represents the area of perfusion of the artery that's occluded, and the red represents the area that's destined to infarction. And what happens is the longer you have occlusion, the more infarction there is, and it starts in the endocardium and works its way out. Okay? I won't go into why that is. If you don't know that, come see me afterwards. But this is the major determinants of infarct size. Time of occlusion, the oxygen demand during occlusion, all of these things in yellow are the things that we can measure with contrast ultrasound. We can measure the true risk area, which is the size of the perfusion territory of the infarct-related artery minus the extent of collateral blood flow. We can see whether or not there is either spontaneous recanalization or if there is microvascular reflow versus no reflow after doing some sort of a revascularization procedure. Okay? I won't go into this. I'll just show you some examples of what this looks like in patients. So here's an example of a patient presented with acute anterior ST elevation MI to our emergency room. There was no question that this person was having an anterior STEMI. Okay? We knew that. We use contrast echo a lot in our ED to diagnose acute coronary syndromes when we don't know. But this is an example where we did know. But here you can actually tell exactly what's going on in terms of perfusion in this patient. So here you can see that the distal septum is akinetic. The apex is completely akinetic to dyskinetic with an apical thrombus. Distal lateral wall is also akinetic. And here with perfusion, you can see that indeed the apex has no perfusion at all. But look at this. There actually is perfusion right through here. This whole septum is perfused. It's akinetic, but it's perfused. And the reason for that is it is ischemic, but it is destined to live if you open up the infarct-related artery. Okay? Here you can see in the distal lateral wall, it's akinetic, but it's akinetic because of subendocardial perfusion defect. The epicardium has decent blood flow. So here you can see transmural differences in blood flow. So this is a transmural perfusion defect, transmural perfusion, okay? Viability, perfusion, and here during coronary occlusion, this area has a subendocardial defect, right? Compare that to the patient below, which is a patient who is transferred to us after receiving thrombolytic therapy. And here you can see, again, in this person, there's complete akinesis of the distal septum and apex. But what do you think of perfusion? It's completely normal. There really is no perfusion defect. If anything, watch the destruction and the replenishment. Destroy, it comes in really quickly. This is essentially reflow that's achieved with thrombolysis. So you can tell this is a person who received thrombolytic agent at an outside hospital and was helicoptered to our institution. We wanted to know whether or not there was patency achieved of the infarct-related artery. And we know from this picture that indeed that this person had recanalization of the epicardial. Normal perfusion, but a lot of post-infarct stunning. In terms of knowing this information before revascularization, this is a study that we published many years ago, and this is, as far as I know, I think this is the first demonstration of this. If you actually do contrast echo in patients who are having ST elevation MI, one of the things that we know is that it doesn't matter how long the coronary artery has been occluded. If you have the presence of good perfusion in the infarct-related artery, either because of a small amount of residual antegrade flow or collateral blood flow, that you will almost always recover resting function, whether or not you do PCI early or late. Essentially, the presence of any perfusion into the infarct-related artery territory will tell you that that area is destined to improvement if you improve blood flow, okay? Now, contrast echo hasn't just been used in the setting of acute MI. It has been used also for the diagnosis of coronary artery disease. So how do we, non-invasively, how exactly do we do this? What do we do on a daily basis to diagnose coronary artery disease? Well, we don't look at blood flow at rest. We do stress. And the reason why we do stress is the vast majority of our patients with coronary artery disease do not have flow-limiting stenosis. So normal blood flow is 1 ml per minute per gram of tissue, and because of autoregulation, blood flow really doesn't start going down at rest until you have about 85% stenosis or more. In order to detect the presence of this moderate to severe stenosis, we look for flow reserve. We give dipyridamole, dobutamine, exercise. If you have no stenosis whatsoever, you'll increase blood flow by 3 to 5-fold. You'll see an increase in wall thickening if you're doing stress echo. If you have a moderate stenosis, flow will not go up as well. This is exactly what we do with nuclear. It's what we do with dobutamine stress echo for looking for wall motion abnormalities because of this. And this is exactly what we do with contrast ultrasound, which is to either look at resting blood flow reduction because of a critical stenosis at rest or a stress-induced abnormality. I won't go into this. Let's not worry about that. This is what this looks like. This is a patient who presented to us with chest pain, did not have ST elevation, had dynamic ST changes. They were in the ED and they had ST depression and they came back up, gave nitro, kind of kept on going down and up. And this is what the contrast ultrasound looked like on this patient. So this is at rest without stress. Watch the subendocardium here. When you guys are looking at these, by the way, your eyes should be looking only at the end systolic frames. Forget the diastolic stuff and in between. Try to just look at the end systolic frames. I won't go into why that is, but those are the things that you should be looking at. So here we do the destruction and replenishment, and watch the subendocardium here. Do you see that little defect in the subendocardium? Do you see the darkness at the apex? You guys see it? Kim and KK, can you guys appreciate that? Yeah. So here at the apex, you see that there's a little rim of darkness right after the flash. You see that here as well. Here comes the flash. Right there, and you see that little area right in through there that's delayed. That essentially tells us that this person has a flow-limiting stenosis at rest, more than 85% stenosis because he has resting hypoperfusion. Here is the angio of this person, which of course does show a critical stenosis in the LED, certainly more than 85%. And so we were able to diagnose in literally 2 minutes at the bedside that this person had resting hypoperfusion as their physiology, and then that this was not from this wall motion abnormality here was not from an old infarct, that this is completely viable tissue, completely viable. The whole thing eventually becomes perfused. Do you see how the apex becomes completely perfused at the end, but it's slow in the subendocardium? That means there is a critical stenosis, resting hypoperfusion. Now, in terms of doing stress and looking at stress-induced perfusion, if there's anything that you're going to remember from the perfusion talk, remember this relationship. This is the relationship between blood flow and wall thickening, radial wall thickening, which is what our eyes look at when we do stress echo during dobutamine. So normally, our wall thickening is about 30%, 25 to 30% wall thickening, okay, at rest. This is just looking at wall thickening at peak dobutamine in a dog model of graded coronary stenosis. And so these are the normal segments right up through here where blood flow went up to 3.5, 4, 5 mLs per minute per gram of tissue. So this is normal wall thickening. This is critical stenosis down through here, okay? But look at this. If you have a completely normal segment and you have another segment that has a moderate, even moderate to severe stenosis, where instead of going up to 4 to 5, you're at 2 to 3, look at this. It plateaus. It is very difficult for you to tell a wall thickening abnormality if you're normal versus mild to moderate stenosis, okay? Nobody ever said that wall thickening and blood flow was a linear relationship. It's not. This is why stress echo, no matter what you do, exercise or dobutamine, only has a sensitivity in the 70s. This is why. It's not because you're useless as an interpreter and you can't see the wall motion. It's because it's not there. If you use more sensitive things like strain, you can pick these things up, but it's not there. This is physiology. This is with quantitative measurement of wall thickening. So you're not going to see moderate stenosis. If you look directly at perfusion, you have a chance of looking at the blood flow disparity between this segment and one of these segments, okay? This essentially shows the same thing. Here is an example of that, and I have many examples. I like this one. This was given to me by Tom Porter. There's no destruction replenishment here. This is just looking at the contrast. This is at rest, intermediate dose dobutamine, and high dose dobutamine. At rest, you can tell wall motion is normal. Just look at the end systolic frames. Perfusion is normal. As we go intermediate and high dose stress, does anybody see a wall motion abnormality? I don't. Okay? Do you see a perfusion defect? I do. There's a cutoff here at the apex. There is this is a person who actually had a 70%, 60-70% RCA stenosis. You can even start seeing it here at intermediate dose dobutamine, where just look at the end systolic. And end diastole, that the inferior wall is moving into a rib artifact, so you don't want to look at that anyway. But here you can see that there is definitely a perfusion defect here in the inferior wall that you don't see in the anterior septum. And because of that, many people have shown, this is just one of the studies, have shown that when you're comparing perfusion to wall thickening, that sensitivity will be higher not only at peak dobutamine, but even at intermediate dose dobutamine. This is important because, as you guys know, during stress echo or dobutamine echo, we don't always get people all the way up to the target workload, okay, for many different reasons. So, and you can also detect multivessel disease much better as well. So, there are no applications right now or indications in the US or elsewhere for myocardial perfusion imaging for contrast. Despite that, we are using it a lot in an off-label use in the emergency department and people who are having chest pain. We use it a lot for bedside detection of viability, and I haven't gone into that here. I gave a talk earlier today on detection of viability, but we're using this a lot in off-label uses. Do you want me to talk at all about research, or? Okay, Kim has given me the okay. So there's lots of different research applications for this technology as well. Don't write anything down. Just look at this and enjoy it, because some of it is kind of fun. This is kind of the future stuff. These are the research applications using contrast ultrasound. It's a really good research application, you know, for any disease state where you're interested in perfusion, because it's an easy, cheap way of looking at not just perfusion, but to also be able to evaluate capillary blood volume, vascular organization. So I've got clinical trials as well as animal research going on where we're studying angiogenesis and arteriogenesis, stem cell therapies we're doing in patients and in animal models, and using contrast ultrasound to tell us what's going on. I'll show you a couple of slides on molecular imaging where we make the bubbles smart and make them home to areas of disease and stick to them, but also using ultrasound and bubbles for gene and drug delivery and for dissolving thrombus, okay? These are all the really neat research applications. And I'm not going to go into all of these. I don't have time. But just be aware that they're out there. In terms of using the unique aspects of contrast ultrasound, here's an example of using the unique information, the destruction replenishment, to tell us how hyperlipidemia participates in decreasing flow reserve in patients. So all of us know that hyperlipidemia causes endothelial dysfunction, and it's true. But the other thing that hyperlipidemia does is it makes it so that the blood becomes more viscous, the red cells don't deform as much, and they don't move through the capillaries nearly as well. So these are contrast ultrasound curves at baseline and during different amounts of hyperlipidemia, induced hyperlipidemia, showing you that with these slower curves here, that red cells moving through the capillaries is much slower during hyperlipidemia than in the absence of hyperlipidemia. And this is all during hyperemia, okay? So this is using contrast ultrasound to understand what are the determinants that allow blood to move through the capillaries. And this is a big advantage of contrast ultrasound, and it's being used for those things. This is another extreme example of this. This was a patient of mine. This was the index case that led to a clinical trial. This is a disease state called PNH, paroxysmal nocturnal hemoglobinuria. This is a defect of the complement system where your body's ability to stop complement destruction of red cells goes bad. And what happens is your body starts destroying red blood cells. Okay, you lack CD55, which is decay activating factor. And what we did was I had a patient who came in with a cardiomyopathy, LVEF of 34%, and we ruled out coronary artery disease, iron in her heart, all the other things that could happen. She had PNH, and I thought that this was probably due to a microvascular cardiomyopathy, that she was essentially ischemic at rest because she had all these nasty, stiff red cells that wouldn't move through the capillaries. So this is during hyperemia at her baseline state. She got put on a drug. A brand new drug that was developed about 2 or 3 years ago that decreased complement activation in the body, called Soliris. Her EF markedly improved, and here you can see the rate at which her red blood cells move through the microcirculation also improved. So this is a great research application showing you that you can understand disease processes that affect blood moving through the capillaries using contrast ultrasound. So kind of fun. I'm not going to worry about this one. I'll leave you with one last thought, because we're now going away from clinical application to fun future stuff, but you deserve to know about the stuff that's in the future. Molecular imaging is something that's being developed for all different forms of imaging. Nuclear, MRI, CT, all forms of imaging are developed ways of doing molecular imaging by making smart contrast agents. The same thing is being done for contrast echo. And the reason is that contrast echo is a very powerful technique if you think about it, because it's portable, it's available, and it gives you information immediately to the clinician. And so here's just one application of using molecular imaging that we're developing for human use. We're very close to the first clinical trials with this agent. This is a venule, and do you guys see these little things right through here? These are leukocytes that are rolling on the venular endothelium. What I've done is I've made this muscle tissue ischemic for 5 minutes and then let it go. And in that very brief period of time, what happens is on the endothelial surface of these venules, this triggers the upregulation of something called selectins. Selectins are these adhesion molecules that are responsible for grabbing leukocytes and having them roll, as you're seeing here, this is our rolling leukocytes along the endothelial surface. And what these leukocytes are doing is they're sniffing. They're sensing their environment to say, hey, something happened here. Do we need to have a full-blown inflammatory response or not? Okay? So this is a really interesting phenomenon, this rolling. And the reason why it's interesting to me is the fact that if you become ischemic, either in your heart or muscle tissue or liver, these selectins will come up and they will stay up for about 16 to 24 hours. And so what we've done is we've taken bubbles, and on the surface of the bubbles, we put the exact same thing that's on the leukocytes that's finding the selectin. So the selectins on the endothelial surface are binding to something called PSGL1. We put recombinant PSGL1 on the bubble surface so that the bubbles will actually stick to the same thing. So this is what this looks like. So here is a converging venule. You see all these leukocytes rolling over here. Here are these smart microbubbles, and all I've done is to do an intravenous injection, and then I wait about 5 minutes. After waiting 5 minutes, you see all these bubbles are not moving through like you saw earlier. They're stuck to the vessel surface. Lights on, lights off. So these are fluorescent bubbles, and these are the ones that are targeted to the selectins. And here you can see that in post-ischemic tissue, that there's this huge number of bubbles that get stuck in these venules. They don't stick if there's no ischemia. But if there's ischemia, they stick. And the reason why we're developing this is for all those patients who come into the emergency room saying, I had chest pain, but it was 2 hours ago, or an hour ago, or 5 hours ago, and you have no idea if it was because of ischemia or bad dumplings, okay? You have no idea. And so these patients come in, you do an intravenous injection of this smart contrast agent, it will stick in the myocardium, and you just image 10 minutes later. And this works all the way out to about 12 to 16 hours after the ischemic event. This is a mouse model of I had chest pain. So essentially what we did was we tied off the LAD of the mouse. Here you can see a perfusion defect in the anterior territory during ischemia. We then reperfuse after 5 minutes, no infarction, wall motion comes back to normal. But here you can see 45 minutes later, we see all of the smart bubbles that are stuck to the area that was previously ischemic sticking in the anterior myocardium. So we're developing this as a clinical technique to allow you to very simply at the patient bedside figure out whether or not somebody's chest pain was from ischemia or not. And then there's one other application that I think molecular imaging is really going to be interesting for, which is to detect atherosclerotic disease at a very early stage, very early stage. I think, and I'm not alone in this, I believe that atherosclerosis is a curable disease if you can find it early enough, okay? And the trick is, how do you find it early enough? So this is a mouse model of atherosclerosis. I won't go into the model, but this is 10 weeks, 20 weeks, 40 weeks of age. And here you can see that at 40 weeks of age, everything that's dark, this is the aortic arch, which I've splayed open. So this is the aortic arch and the descending aorta. Everything that's dark is plaque. Almost no plaque at 10 weeks of age in these mice. If you look at 40 weeks of age, there's big, huge plaques. At 20 weeks of age, it's these intimal xanthomas, fatty streaks, which is what all these things are, is fatty streaks. But here at 10 weeks of age, we really don't see much in the way of plaques, but we just start to see monocytes entering into the vessel wall. This is essentially the very earliest start to atherosclerosis. And when we give smart bubbles that will stick to the same things that those monocytes are sticking to early in atherosclerosis, we can actually see atherosclerotic prone areas lighting up. This is before there's big plaques, long before there's plaques, where we can actually detect the disease here at 10 weeks of age. This is the atherosclerotic mice in yellow. The green is the wild-type mice. These are the two different targeted agents that we looked at. This is a control agent. Here you can see this signal enhancement coming, showing this is the first time anybody has ever shown that by using molecular imaging, you can diagnose atherosclerosis at a very early stage. So I'll go ahead and end up there and turn it over to Kim Lang. Just a couple of words in conclusion, which is, for those of you who aren't doing contrast ultrasound, I don't think that you are doing a service to your patients. I think that there are some labs that use it a lot and some labs that use it more judiciously. But I know from my own experience that if you are not using contrast, you are actually missing things that you need to be able to find. It really enhances your practice of cardiology. As I showed you with some of the data from Bill Zogby's laboratory, it really does improve patient care and decreases cost. But the other thing is that if you're interested, I'm actually the vice chair of the National Board of Echo. So you better know, if you're going to take the Echo boards, you better know it as well, because there's actually a fair amount of contrast now in the Echo boards. And so I think that by virtue of the fact that we see people in the room who are interested in seeing this technology in action, that it's a sign of people's willingness and desire to improve their practice of echocardiography. And the other thing is that you know, as part of my role in the American Society of Echo, I actually help run a meeting together with Jim Thomas of the Cleveland Clinic. So we're the co-directors of Echo Hawaii. This is not a bad place to go learn echo, guys. This is held every January. And the reason why I mention it is this is the one meeting of the American Society of Echo where we have a specific focus Most of it is non-contrast. It has everything in echo. But this is the one meeting where we do discuss contrast in some detail, called the Concerto program. And next year's meeting is going to be January 21st for 25th, and it's not so far for you guys to come from here to Hawaii, and it's a beautiful location, and it's a very high quality meeting. So for any of you who are interested in hearing more about contrast and seeing this in action, think about coming to Echo Hawaii as well. So thank you so much for the invitation.
PJ, can you show us how do you change the mechanical index on the IE33? So this is the output, and there's a knob here. So as you turn the knob, you can see the mechanical index indicator on the screen here, that it has increased from 0.24 earlier on to now to 0.7, 0.9. So this is how you adjust the mechanical index on the machine. Okay, thank you. Good. So PJ, can you show us where is the gain button?
Actually, but before you do, PJ, can you do me a favor? Can you go up and down on the focus and watch what happens to the mechanical index as we change the focus?
So this is the focus here.
Do you guys see that? So the MI has changed as we've changed the focal. The same thing will happen if you just change the depth.
This is the focus.
So remember that the different settings will also change it. So if you go to different LVO pacification settings that we do there, you always need to be mindful and look at the mechanical index of what you're doing, because other things will change it besides just changing the power knob.
Okay. So PJ, can you show us the gain? How do you adjust the gain in LVO setting? So that's a TGC, and as she turns the knob, you can see that it gets brighter. Alright, so that is very bright, and now it's almost black. And this is the focus here that mentioned earlier. Alright, so PJ, maybe we can go on to show them on the screen the SonoView protocol. Right, so this is a pre-installed. Can we see the other side? Right. Yeah, so this is a pre-installed SonoView LVO protocol that is a preset, and that has been installed in the IE33 here. And this is the LVO button. Once you get into the protocol, you need to press here again. Can we see the activation button for LVO? Right, great. Yeah, so once you press this, when the button lights up, the LVO protocol is on. And when you press it again, you deactivate it. And so now you're activating LVO. So the MI goes to 0.24. Can you press it one more time, please, PJ? So when you press it once again, you deactivate LVO protocol, you go back to regular 2D. So you see the MI goes back to 0.9. Okay, so I think we have gone through the bubble, the IE33 settings, and perhaps we can start with the actual left ventricular opacification study. So, Xiangqi, are you ready to give the bubbles?
Yes, I am.
Okay.
So while they're doing that, one of the other things, do you notice that you don't see anything when you go to the contrast mode? Does that worry anybody? It shouldn't worry you because there's no bubbles. What the machine is doing is it's going into one of these very specific bubble-sensitive modes that's making it drops out the myocardium and just allows you to see bubbles. Now, one of the ways that you can tell which setting you're in is look at this over here. So this is 1428 with a triangle. This essentially means that this is tissue harmonic imaging, okay? And for this one, it's low frequency broadband with a P circled for penetration, pen-gen res. If you turn on the contrast setting, PJ, you see that it becomes this bubble that's oscillating. Okay, this is essentially something called power modulation imaging, and this is with the res setting. There's lots of separate contrast controls. One of the things that I highly recommend that you guys do is, depending on what system that you're using and what bubbles you're using, I highly recommend that you get together with your reps or somebody who has a lot of experience to just get a good preset so that you don't have to do a lot of changes, that is essentially on your system and you can just push your preset button and it goes. So, okay?
Okay, okay, so this afternoon, we'd like to show you 3 different scenarios. The first scenario is when there's underdose of contrast. Second scenario is when there's overdose of contrast. And third scenario is when we have just the right dose, but with either too fast a flush or too slow a flush. So we'll do the first scenario first, is when you do not give enough contrast. Sang-Chu, would you just like to give like 0.1 mils of contrast here?
Sure. So I'm giving the contrast now.
So note that we have activated LVO setting with an MI of 0.24 here. And he has given some contrast, and PG is the probe is at the. Are we showing the apical 4 windows here? Okay, so this is apical 4. Right. So anytime you can't see anything, you're not sure where your window is, go back to real time. Right. So there's a little bit of contrast coming in. You see the LVO brightening up.
This is a situation where I would increase the gain to kind of see what's going on. There you go.
So you see the difference. When you increase the gain, it's so much clearer.
The other thing to remember about increasing the gain is with left ventricular opacification, you're trying to look at wall thickening, right? Can you tell wall thickening if all you see is endocardium? No. There's also cardiac translation. To tell wall thickening, you have to see epicardium and endocardium. So for example, over here, I can't tell where the muscle is, where it ends. I can't tell where the epicardium is. And because of that, if you increase the gain a little bit, or sometimes increasing the mechanical index, you'll actually bring out where the epicardium is. And this is important because you're not just looking for endocardial excursion, you're looking for thickening, okay?
So as you can see in this LVO study, as time passes by, more and more bubbles are getting destroyed, and the concentration is dropping, and you can start seeing swelling. So there's quite a fair amount of apical swelling here. And when you have apical swelling, sometimes it gives you a false sense of motion. So it makes you feel that the wall, the apex is coming in when actually it may not be. So it is important not to have this apical swelling.
Why don't we try increasing the focus to the apex and see what happens here. With the concentration is low. If we move the focus up to the apex, it fills it in a little bit. Do you see that? Do you guys see how there's less swirling when we move the focus up?
Right.
The reason for that is when you move the focus up, the lines at the apex are much, Kim referred to this, the lines are much thinner, and you have less line overlap, and so there's less, with less line overlap, there's less power given to each bubble, and so there's less destruction. Okay, so we can probably move it.
You see here that even if the focus going up, if you do not have bubbles, it would still, it will help, but you know, eventually it will swell, it will just continue to swell more and more. Right. So Sang-Chu, what do you think we can do to, besides moving up the focus, what can we do to improve this concentration of bubbles there?
I think we can raise up the patient's hand and also massage the vein to improve the flow of the contrast to the heart.
Okay, so maybe you can try that and see whether it works. Okay. I guess the concentration is so low. Well, it just seems to help a little bit. Right. The other way is maybe we give a bigger flash.
Okay, I'm giving now.
And just in terms of style and how you do things, in our laboratory, we do everything with a continuous infusion.
I see Sang-Chu is giving the flash here. You can see it coming to the RV and lightening up the LV. So sometimes there may be bubbles that stays in the veins, in the peripheral veins. If you give a bigger flash, you can actually push the bubbles forward into the heart.
Yeah, so the issue is if you're going to do bolus injections, you're going to have to live with the fact that you're going to have to interrupt your, if it's just one person doing this, you're going to have to interrupt your study, give a little bit, then go back to the heart, interrupt it, give it. And if you're going to do it as a continuous infusion, it's a little bit more work up front of setting up an infusion pump, but then essentially you start it and you don't have to mess with anything. Plus we have an infusion rate that we know with each bubble and each system, the correct infusion rate that will work essentially for everybody. And so it just depends on how you want to do things. So every lab is a little bit different.
Okay, so we are more or less completed the first scenario. We have shown to the audience what happened when you do not have enough bubbles and how you can troubleshoot that. We'll now go on to the second scenario when we have given too much bubble. So PJ, is your window there? All right. So sometimes you may need to go in and out of the LVO setting in order to get your window. Right. So Xiangqiu, would you like to give a bigger dose of bubbles now?
Sure, giving now.
So how much would you like to give?
I'm giving 1 ml.
Okay, so Xiangqiu is giving us, Dr. Chai is giving us the patient 1 ml of contrast. You can see the contrast coming into the right ventricle, and then it's coming into the LV, and you can see the huge amount of attenuation here. And when you have attenuation here, you actually obliterate the endocardial wall of the basal and mid segment, and now it's just nice. Can you give a big flash?
You also saw a little perfusion as it was moving through too.
Okay, I'm giving the big flash now.
Right. So I would like the audience to focus your eyes on the basal segments and see what we meant by attenuation. Attenuation is created when you have too many bubbles, too high a concentration of microbubbles inside the LV cavity. The attenuation is not coming.
Okay, coming.
Can you give
now.
more bubbles?
Yeah, more flash now.
Give a big hard flash. Well, this overview seems pretty good. You know, we are going back to our third. We're going down to our third scenario. So. All right, you do see some attenuation coming in here, but it wasn't as dramatic as when you first injected earlier on. So is anybody in the audience who would like us to repeat this so that you can have a better idea of, you know, what's LV attenuation and, right? Okay, so I think, I think most of you have seen that what I meant by too much dose and too much attenuation there. And Xiangqiu, we are just not seeing the attenuation, you know.
Dr. You want to give like 1 more ml or?
Yeah, can you give more contrast?
Okay, sure, I'm giving now. And follow with a flash, is it?
Yes,
okay.
A fast, big flash.
Kim, before we do, I was wondering if we could actually have the show in the camera what the syringe looks like of the bubbles, because the one of the things that's happened. Oh, be careful. Not sure if you guys see this or not, but if you take a look, you can see that the bubbles are starting to come out of solution or starting to layer in the syringe. And so this is a situation where sometimes what you have to do is to disconnect the syringe off of the IV and just essentially rotate it, you know, either agitate it or rotate it to get them back into solution and then inject them. And I think that's what happened here is he gave a big injection, but it wasn't really rich with bubbles because they had settled up. Remember, these are bubbles, and what do bubbles do?
Can we have
they
the
float.
video? Can we have the video on that syringe of bubbles? Can you show us the bubbles and Xiangqiu how you are?
So essentially, I'm just trying to rub the syringe to reconstitute it again, because just now there's a lot of sediments forming.
And you can tell that's happened because what happens is you see the little bubble cake. There's like a big white cake up at the top of the syringe. So this should get it into solution, and then you'll be able to give a bolus.
Right.
While we're doing this, while we're waiting, why don't we try increasing the mechanical index and show what happens when the mechanical index is too high. So if you can increase the power. All of a sudden, what you see here is swirling throughout the whole left ventricular cavity. And that's because you're essentially exposing microbubbles as they're going through the RV and then from the LA into the LV again. And you're slowly destroying these bubbles so that you're just getting this swirling in the LV apex. The other thing is you see you're starting to bring in myocardial signal as well. Not myocardial bubbles, myocardial tissue.
So this brightness that you see is not because of a gain, increase in gain, but because of an increase in mechanical index. So, Xiangqiu, are we ready to?
Yes, we are ready.
Okay. All right. Are you giving the contrast?
Just give me a second, Dr.
Okay, sure.
So I'm giving 1 ml of contrast now, followed by a rapid saline flush.
In terms of settings also, you see the P low here, that's persistence. Ideally, your persistence should either be off or low.
So you see the contrast gushing into the right ventricle and gushing in the LV. So this is huge attenuation. It's very convincing, there's no question, right? So what can we do to decrease this attenuation? All right, so as time passes by, the attenuation drops, and then you get a fairly good LVO, right? So if you do have too much attenuation, one way you could do is actually to switch back to real time. Deactivate your LVO, go back to real time, MI goes up to 0.9, and you destroy bubbles. And then you reactivate your left ventricular opacification setting and goes back to LVO, and there's lesser of attenuation there, right? Yep. So we have shown you the low dose and the high dose, and now we would come to the final stage and finish with just the right dose of 0.5 mils as recommended in our protocol, but with either too much or too fast a flush, and with just the right flush. Right, so this is just the last scenario. So maybe we go back to real time, destroy some bubbles. And Xiangchu, we'll give 0.5 mils next with a fast flush.
Sure.
10 mils of normal saline, fast flush. And okay, so you see this is a very low concentration of bubbles here. It's all swelling at the apex here. And usually we keep the focus at the mitral level here. Okay. I think we can activate the LVO setting now. And PJ, can we bring the focus down to the mitral level, the mitral annulus level, please? Okay, thank you. Right. So Xiangchu will just give 0.5 mils followed by a big 10 mils fast flush.
Okay, so I'm giving now.
So this is just to demonstrate to you the importance. You can be giving the right dose, but the importance of your normal saline flush as well. It comes with practice, you never get it right at the first few tries. So after some time of just doing it, you realize that, what is the speed of the flush and how much you should give, right? But you can see here, when you flush too fast, you get attenuation. But just hold your transducer there. Eventually, it would come down, and as the bubbles get destroyed. Right? So how about we go back to real time, destroy the bubbles again, all right? And then now we'll just do it perfectly right, according to the letter. So we'll just give 0.5 mils of Sonoview, followed by 10 mils of normal saline, flush, slow flush. PJ, I think we need to destroy the bubbles more. There's still a fair amount of contrast inside.
This is probably a good time to talk about half-life. So the bubbles generally, depends on the type of bubbles. For Sonoview, bubbles generally have a half-life of just a couple of minutes, about 2 minutes or so, 2 or 3 minutes. But they'll last in the circulation for much longer. So you'll see the bubbles for 10, 15 minutes in through there. But and for anybody who's interested, they're actually cleared by the reticuloendothelial system, by the liver and the spleen.
So, Jonathan, how long do you think we can keep the reconstituted bubbles before we? Is there a time frame that before we have to use it or discard it?
Yeah. So it really depends on the bubble type. So for Sonoview, it's several hours. For Optison, it's an albumin bubble. It actually comes in solution, so there is no, it's already reconstituted and it lasts for months in the refrigerator. And for Definity, after you've activated it, you've got about 4 hours, 4 or 5 hours.
Okay, so I think we can proceed to the last, the final scenario of this workshop. Okay. So, Xiangchu, are you ready to give the 0.5 mils of Sonoview?
Yeah, so I'm giving the 0.5 mil now.
Okay.
Followed by a slow flush.
So when the bubbles gush in the right ventricle, it also helps to assess the right ventricle function from here, because you can see it really lights up the right ventricle. Right, so if the right dose and the right flush, you can get a nice left ventricular opacification, as you can see here. The attenuation is just nice at the mitral level. There's no apical swelling. The only part that we are not so happy with is that we do not see the epicardial border, as pointed out by Jonathan. And so we do not see the entire wall thickness of the lateral wall of the left ventricle.
That's where you can actually change your settings a little bit. One of the other things, one of the things that has been shown with contrast is that it improves your ability to measure LVEF and volumes. It makes for less inter-observer variability, but it much better matches what you get with MRI. And one of the reasons that you see here, which is you truly get to exclude the trabecula and the papillary muscles. Do you see how all the trabecula have essentially disappeared into the contrast volume? So if you measure end systolic and end diastolic volumes without contrast, and then with contrast, it's always a little bit bigger because you've excluded those trabecula, and it actually much better matches what the cardiac MR values are. The other thing for sonographers out there, people who are doing their own contrast studies, here's where it really helps as well, is defining the true apex. I can't tell you how often we see foreshortening of the LV apex, and when you've got the contrast in there, the sonographer, whoever is acquiring the images, really is able to see whether or not there is foreshortening or not. So can you actually show them foreshortening and no foreshortening? So you can really tell apical foreshortening and when you truly have the LV apex.
PG, are you showing us the foreshortening of the LV apex?
Yeah, she actually did it as right there it is. You can see that as she goes from, let's bring the acoustic focus to the apex so you can see it a little bit better. There you go. Now as she kind of turns laterally from one side to the other, you can see that you can get, there's foreshortened, and then she'll turn over to the apex, the true apex, where the contrast goes further out into the apex. Contrast is getting a little low.
Right, contrast concentration is dropping. Right, so I think we have more or less demonstrated to the audience how the left ventricle LVO can be done, and what are the pitfalls to look out for and how to troubleshoot. Is there any questions from the audience?
Different bubbles, it's in the package insert, and so it's actually different for different microbubbles preparations. Most of them, for example, we don't use, I'm not sure what it is for SonoView, I think 5 mLs, is it 5 or 10 mLs? That's the max. Yeah. Yeah, and you can use the entire vial. Generally, you don't even need to use the entire vial for SonoView for a left ventricular opacification study. So it really depends on which agent. The nice thing is the safety studies have been done to show that you can go essentially to 15 times the maximum dose without having any kind of bioeffects in patients. One of the things I wanted to kind of clarify that Kim was talking about is, Kim's contraindications are very stringent. So, for example, in our laboratory, we actually do people with acute coronary syndromes all the time. We do patients with recent MIs. The FDA has actually taken away those contraindications. They've also taken away the mandatory waiting period, with the exception of people who are very hemodynamically unstable. And then there still is the monitoring period. So essentially, we do not have a post-contrast monitoring period, and we use it all the time, not just in people with recent MI, but actually even in patients who are having an acute coronary syndrome if we need to. And so, yeah. The other thing is the pulmonary hypertension patients. There was a recent study that was just published that actually showed that the contrast is actually safe even with people who have significant pulmonary hypertension, PA systolic pressures well over 50. The key thing, though, in that kind of a situation is probably use as little contrast as you can get away with, okay? So always do a risk-benefit. If you really don't need contrast, then don't do it. But if you need contrast to answer the question, even in people who have pulmonary hypertension, you can actually give small amounts. Just give as little as you need to get away with.
So, Jonathan, could you concern by FDA about this, the reason behind the black box and subsequent, downgrading of it?
Yeah, the safety issues with the contrast agents stemmed from post-marketing surveys. So what happened was The US FDA, after close to 2 million doses of contrast in over 1 million patients, detected 6 deaths within an hour of receiving contrast. Now, if you think about who are the patients who are actually receiving contrast, bless you. The patients who are more likely to receive contrast are patients who are in the ICU, who are difficult to image, who are on ventilators. Guess what? We do echocardiography in people who are very sick and may be dying in the next hour. And so 6 in 2 million doses, in my mind, is not a lot. And so, but it was enough to trigger the FDA to put on a black box, and it triggered the American Society of Echo to do retrospective as well as prospective studies looking at the safety of ultrasound contrast. In one study done by Mike Main, he actually showed that if you took patients who were in the intensive care unit and in the hospital who didn't receive contrast versus those who did, mortality was actually less in patients who received contrast. I don't think that that means that contrast makes people live longer. It may reflect that you actually had better information. I think it was just a statistical glitch, but definitely the stuff is not killing people. And then in another study that was done that was published, a multi-center study, we found that really the rate of significant reaction was about 1 in every 10,000. So that is about 10-fold less than what you'll get with just about any other contrast agent that we use with other imaging modalities such as CT or angiography or things like that. So based on those things, those observations, the FDA rolled back the safety. So essentially they've taken away all of the bite out of the black box. The FDA has never withdrawn a black box warning, ever. There's no history of them ever taking it away. And so they're actually under consideration right now of actually taking away for the first time a black box warning off of the ultrasound contrast. They're unlikely to do it, but that's kind of the history of it, which was I was actually part of this effort. The other problem with the FDA was the FDA thought that contrast was a luxury, that it really didn't add anything, that it just made people who are mediocre into better. They didn't understand the fact that it actually really helped to make diagnosis in people who are critically ill and to really improve patient care. And they didn't understand that. And what the FDA does is they weigh risk and benefit. It's not just risk, but it's also benefit. And so we educated the FDA in terms of why we're using this stuff, plus we showed that the risk was really pretty low. And based on that, they took away all of the major contraindications for the black box warning.
Any more questions from the audience?
Can you show us some of the images of masses?
You have any images of masses?
Images of masses. Actually, we had potentially a second candidate with a mass in the heart, but he was not too keen, and yeah. So he had this mass that is in the interventricular septum, and we couldn't decide whether it's coming from the right ventricle or the left ventricle.
And I'll show some tomorrow at the contrast session as well. Here's where contrast echo really helps with masses. Number one, it helps you figure out whether or not a mass is real or not, whether it's artifact or not. The second thing that contrast does is it tells you where the mass is attached to the heart, which is important. Third thing that it does is it tells you whether LV function, where the mass is attached, is normal or abnormal. That is key. Thrombus attaches where LV systolic function is abnormal. If a mass is attached to a normal functioning area, then it's probably a benign or malignant tumor and not from a thrombus. And then the fourth thing that it does is allows you to do perfusion to be able to differentiate. Thrombus is not perfused. Some of the masses are perfused, but it even allows you to differentiate certain masses from each other. So for example, melanoma, medium perfusion. Myxoma, very heterogeneous perfusion. Hemangioblastoma and hemangioma, incredibly high amounts of perfusion. And so if you come tomorrow, you'll actually see what some of these things look like. But that's really the role of echo, the most important of which is to tell you where it's attached and what the wall motion is like underneath it.
So don't forget to catch Jonathan's talk tomorrow. So is there any more questions from the floor, Kiki? If there's no more questions, then we'll
Let me leave with one word of warning to most of you. How many people in the room are using contrast right now? Yes, some. So for those of you who are interested in contrast, let me tell you what works. What works is you going to an institution that uses contrast a lot and go and watch how they do it. Look at the settings, write down the settings, look at how they handle the contrast material. That's the way to learn how to do it. And it doesn't take much time. So find an institution that's using the contrast material that you want to use and using the ultrasound system that you want to use, and go spend a day with them. Send one person to go learn.
Thank you, Professor Lindner. It leaves me to thank Dr. Tong and especially the Philips people, Ziping, William, Ed, etc., for making this workshop a success. And please feel free to mix around and exchange ideas and have a little bit of tea break behind.